My name is Erica Badgie. I'm the Senior Medical Science Liaison for Mdxhealth. Really excited to have you all join us, and even more excited to have Dr. Weiner here speaking to you guys about our 3 prostate cancer products. I know Dr. Weiner really doesn't need a lot of introduction, but I'll kind of run through some of his, accolades. He's a great guy. He's the Associate CMO of Surgical Services, the Chief of Urology, and the Director of Robotic Surgery at New York City Health and Hospitals. He's also the Urology Program Director, as well as an Associate Professor at the SUNY Downstate Medical School. So we're really excited to have him here with his expertise to walk you guys through our 3 prostate cancer products. I will say most of you are automatically muted with videos off. If you do have questions, please feel free to put them in the chat or raise your hand and we can take you off mute to ask your question. And with that, Dr. Weiner, I'm going to go ahead and switch it on over to you.
Thanks so much, Erica. And thanks everybody for joining. I know you've all probably had a long day seeing patients. I know we're expected to see more and more. So, I really appreciate you taking the time in the evening. I just want to sort of state for the fact, I am not an ivory tower academician. I work, as some of you know, in a couple of inner city hospitals. And so, I really want to take some time tonight to explore some of the prostate cancer adjunct tools that we have in our toolbox that can be used in any practice, really from a community practice to an academic high-level tertiary referral center to an inner city hospital. And some of you may recognize the green background if you've seen me present before. I am reporting here from the beautiful city of Brooklyn, New York. So if you hear some sirens in the background or the loud screams, we all live on top of each other. So welcome to all, regardless of where you're calling in from, and I hope you are enjoying your Grubhub gift certificate. So let's get started. I want to start actually with the title slide here. So a couple of things that jump out to me right away are 1, the model, and 2, the title. So the model is near and dear to my heart because approximately 90+% of the patients that I treat on a day-to-day are of Afro-Caribbean or African-American or Latinx descent. And one of the things I'm proud of regarding the utilization of these tools and Mdxhealth is that they've done a lot of their initial and validation work on a diverse array of patients, and the cohorts are always represented in ethnically, racially diverse patients. And you'll see this borne out in some of the studies that I'm going to present. And the second part is the title itself, and the precision prostate cancer pathway. It really, the 2 words that jump out to me are precision and pathway. And precision because these buzzwords of precision medicine and individualized care, they're really becoming not just buzzwords, but the mainstay of where our treatment paradigms are going. And then the pathway, I'm going to jump into the next slide. The pathway really sticks out to me because this truly is a pathway. And I like to call it the one-stop shop because you have a whole array of tools that are afforded to you through the Mdxhealth platform or menu, if you were, that you can order from a patient who comes in with the elevated PSA all the way through a negative biopsy or a positive biopsy through to a high risk or unfavorable intermediate risk patient, and even into the endpoints of metastases and prostate cancer death. And we hope to not get to there, but it is really nice to have one point of contact, one rep, one billing cycle, one kind of area that you can focus, because as all of you who are providers out there, whether you're a urologist, a radiation oncologist, an APP, a physician extender, resident, whatever, you all know that there is so much noise in this space. There are a lot of competitors. There's a lot of opportunity for utilizing these services, and I find it really sort of satisfying that I can kind of stick to one area and just use it all the way through. So tonight I'm going to go through 3 different platforms that I use in my practice to help individualize the care of my patients with prostate cancer or presumed to have prostate cancer. The first one is a Select MDX, which is a urine test, and we'll go into that in a second, but it's a urine biomarker. Then Confirm MDX, which is a tissue-based biomarker that looks at a negative prostate biopsy, and then the GPS, formerly known as Oncotype DX, when it was with the previous company, and since Mdxhealth has acquired it, they've dropped the Oncotype and it's just left the GPS. So That's for patients who have a positive biopsy and help to decide on what treatment paradigm they're going to go for. So let's jump right into the first one, which is going to be our Select MDX. So this is a urinary biomarker for patients who do not have a diagnosis of prostate cancer, but simply come into you as a referral for an elevated PSA. And we all know that the PSA is extremely flawed. I mean, you'd have to live under a rock to not know that the PSA is flawed, but it is really our workhorse. So we all get the PSA regardless. But I would say most of us are adding to the PSA either the utilization of a urine test, an additional blood test, or an MRI when deciding whether or not to proceed with a biopsy. And I think that this test is a really nice and simple way, because we're all getting urine. Most of us are getting urine on all the patients that we're seeing in the clinics. So, this is a nice way to help narrow down who to biopsy and who not to biopsy. It's almost sort of Shakespearean in a way, to biopsy or not to biopsy. And really the drivers here are two genes, and we're looking at the expression of these genes, DLX1 and HOXC6, which I'm going to go into a little bit more detail on in a few minutes, and then adding in some of the clinical risk factors to really add and augment the strength of this urine biomarker. But just to sort of pare it down to what it'll look like in the office for you. So a patient comes in, elevated PSA, but maybe 67, PSA of 5. Are you going to put that patient through the rigor of a prostate biopsy? Well, you might want to get an MRI. That might be nice to help identify if there's a lesion, but it doesn't tell you, if you get a PIRADS 1, 2, or even 3 in my practice, because the radiology is kind of hit or miss, that the Select MDX will really narrow down for me who I'm not going to biopsy. So you're going to do a gentle prostate massage, not that rigorous PCA3 aggressive prostate massage, just a gentle DRE to express some of the epithelial cells in the prostate, and then have the patient void into the Select MDX receptacle, send it off, and within about 10 days, you get the result. And what you're going to find is that this non-invasive urine test gives you up to a 95% negative predictive value for identifying or sort of ruling out patients with grade group 2 and higher, so Gleason's grade 7 and above. So you can confidently say if this test is negative, with a 95% negative predictive value, that the patient has low risk or grade group 1 or grade group 1 disease, very low and low risk disease, if this test is negative. And that number, the negative predictive value, goes up to 99% for grades group 4 and higher. So this is a really, really valuable test for identifying clinically significant disease on your prostate biopsy. And we're all trying to avoid the not only financial toxicity, but the comorbidity the morbidity of the actual intervention, the prostate biopsy, regardless of how you're doing it, if it's transperineal, MRI fusion, or transrectal ultrasound. So the gene expression of these things, the ones that we're looking at, they measure the mRNA of two primary genes that have been directly associated with aggressiveness of prostate cancer. There's HOXC6 and DLX1, and I'm going to spend a few minutes just so the group is aware of what these two genes, these oncogenes, really do. So HOXC6 is the main driver of this genomic biomarker, and it's responsible for epithelial cell proliferation, or the rapid reproduction of a cell, which is a hallmark of all cancers, not just prostate cancer. But HOXC6, as you're going to see in a minute, was really specifically found to be upregulated in prostate cancer. The HOX gene family is responsible for a lot of different cancer types. It's responsible in the Ashkenazi Jewish cohort for, I think that's HOXB13, for some of the inborn errors, and some of the malignancies that are associated with that particular cohort. But just in general, there's a large family of HOX genes, and HOXC6 was found to be specifically upregulated in prostate cancer cells. And it's also found to be associated with decreased apoptosis of the cell, which is another hallmark of all cancer cells. So as I said, this is associated with higher grades, Gleason score and increased TNM stage in patients with prostate cancer. But it was one of the most upregulated HOX genes in all primary metastasized and castrate-resistant prostate cancer, which I found to be very interesting. DLX1 is sort of another one that's associated with prostate cancer, but it's a little less powerful than our HOXA6. It's involved in the acquisition of epithelial and neuroendocrine differentiation, which is kind of nice because even though it's a small subset of patients, the neuroendocrine population, as those of you who treat prostate cancer are probably aware, these tend to be non-PSA secretors. So even with a relatively low PSA, you could pick up some of these neuroendocrine differentiated patients with the component of the DLX1 upregulation. And in one study that was found to be upregulated in 73 out of 74 patients with prostate cancer and 0 out of 7 those without prostate cancer. So, and in that same study, it was found to be associated with higher TNM stages as well. So between those two genomic, the oncogenes, upregulation of those two, in addition to the comparison of the housekeeping gene, what the biostatisticians and the basic scientists have been able to do is they've been able to analytically validate this biomarker in the lab through translational medicine communications. I mean, this is very much a basic science-driven publication. But then you take that out of the lab and you clinically validate it on over 3,500 patients in 12 published studies. And then what we're also showing is that there's some health economics involved here. So as we become more of a value-based economy here, so we're moving away a little bit from the volume base where providers have to see 1,000 patients in a day. We're moving a little bit as we inch towards value-based. And this, even though it may seem to be a test that costs money, if you're saving the healthcare community of a transrectal or transperineal biopsy, you're potentially saving a trip to the OR and all the additional expenditures. So there was over $500 million in savings to the healthcare system with this test by avoiding unnecessary biopsies. And then taking into the practice, clinically validating it. I mean, the 95 negative predictive value is really strong. And Neil Shore and his large group in the South, they identified a study that showed there was a significant impact in the clinician's decision-making capacity based on the results of Select MDX. So, this article showed it was a multi-center validation study of this two-gene mRNA urine test. And I want to kind of point out something that may not be so obvious, but this Select MDX as compared to some of the competitors like ExoDX or PCA3, this isn't an all PSA, an all-comer PSA. So as opposed to having a tight range of 3 to 10 or 2 to 10, this is for all PSAs. So it's really powerful because in my practice, I'm seeing PSAs 12, 14, 16, and some of those are a significant portion are coming back negative. Well, we may have been able to avoid it if we got the Select MDX, because as you can see here, a negative predictive value of 95%, really powerful. The positive predictive value of specificity, 47%, still pretty strong when you consider all PSAs taken into consideration. But really the value comes into finding a negative result and saying confidently that this test is going to be negative and that your subsequent biopsy will likely show non-clinically significant prostate cancer. If you want to find grade groups 1, by all means, go for it. Go right for the biopsy. But for me, I'm trying to avoid that because of all the anxiety and the downstream effects that come with, the diagnosis, the C word, as we say. So what does the result look like when I get this back, 10 days later or so? I'm hoping for a negative result, and this is what it'll show. It'll show that the patient has a negative result, hopefully, and give you some more information about what the genes involved are if you're interested and how it was derived, molecularly. But what you can safely say to a patient with a negative result is that I feel that you have a 95% chance of not having anything grade group 2 or higher. And I feel with a 99% certainty that we're not going to miss grade group 4 and higher, at least an 8 or higher. So it's a very strong statement to be able to make based on a urinary test that you order in the office. And you know, a number of these patients will be able to avoid biopsy, which is really strong. If you get a positive result, you're going to get a percentage here. I want you to sort of turn your head to the right side of the screen here, which shows, you know, a breakdown, likelihood of prostate cancer, and what the score might be. For me, in my practice, I don't pay as much attention to the percentage. Really, just the positive result is what drives my decision to proceed with the biopsy. What the percentage may do for me, though, is it may help me prioritize the timing of my biopsy. So if I have a list of patients who need biopsies, this patient, if their percentage is higher, may go higher, towards the top of the list. But really, what this is saying is that this particular patient, based on the urinary biomarker, in addition to their PSA, would most likely benefit from a prostate biopsy at this time. So I'm going to stop for a minute because this is sort of the first platform that I wanted to discuss tonight and see if there's any questions from the group. I really want this to be as interactive as possible. Okay, yes, I see from Heather Chalfin, the question is, can men on finasteride use select MDX test? And that's a great question. And the answer is yes. So patients on finasteride will still eliminate the same sort of prostate cells after the DRE is performed. They'll still eliminate those same epithelial cells on finasteride or not. So yeah, the answer is yes, and you will still get the results that you're hoping for. And then I have a next question from Vineet about what is the cost to the patient? Is it covered by insurance? I'm not going to sort of go too far into the cost because I can't really go into that. But what I will tell you is that the payer mix that I take care of is not the private practice group that many of you may take care of. It's a highly variable group. Some have private insurance, some have public insurance, some don't have insurance. And I will tell you that these patients are getting the care that they need and they're getting the test done. And that's one of the things, and this may be, off record, but that's one of the things I love about this test and about the company is that they work really closely with the patients, insured or uninsured.
Dr. Weiner, I don't mean to interrupt, but I'll answer that directly as well. Just so everybody is aware, all the products that we're discussing tonight, any product at Mdxhealth for all of your Medicare, Medicaid, TRICARE, Medicare replacement, it's going to be $0 out of pocket for those patients. For Select MDX, for private insurers, it'll be $100 or less. Most patients pay somewhere in the $50 range. We're really willing to work with patients to get them on plans and assistance and whatnot. And then for the tissue test, confirm MDX and GPS, that'll be $250 or less out of pocket. Again, most patients are going to pay significantly less, but we're always happy to help and engage in any type of assistance patients need. So I just wanted to throw that out there. I'll throw it back to you, Dr. Weiner.
Yeah, thanks for that. Nathan from Marshall, yes, is the amount of urine does it need to be in the first 5 ml after the DRE? That's interesting because we used to say that for the PCA3 test, you had to capture it pretty quickly thereafter. But for us, we just capture the first urine after the DRE, and it should be about 40 ml, which isn't that much, but you don't have to go too crazy. At least in my practice, we don't, and we're getting the results that we need. So I wouldn't go too crazy about trying to catch that first 5 ml. And then the next question is, if you don't do a biopsy at PSA of 5, which is reasonable, by the way, and a year later, the PSA is 7, do you repeat the select test? And the answer is yes. And the reason is, I mean, if you want, right? Like I'm not trying to dictate what you're going to do as a practitioner, but the answer is you can. And the reason is because biologically, these tumors change. Right? Oncogenesis doesn't start as the final product. It's an evolution over time. And so I think that what you're going to find is an illusion. You're going to eliminate the cells that are present at the time that the test is drawn, and whatever is present in the prostate is what you're going to see in the test. So yes, I would say that you can repeat it a year later. And then James asked, do you select MDX on patients with continued elevated PSA with a previous negative biopsy to help decide to do or not to do a biopsy? I would say for me, if they have a negative biopsy, and we'll talk about this next, actually, thanks for a nice segue, James. I don't do another select test because I have a negative biopsy. I would actually proceed to the next test, which is the confirm MDX. So for me, the select test is that first branch point of am I biopsying or not? And once we've made the decision to biopsy, then I'm moving along the pathway to the next step. And then Jay asked, do you use this with 4K? I'll be honest, I don't use 4K. I find it to be very confusing. I think that the results I've gotten from 4K, and again, this is just totally my personal feeling, is that the 4K, results for me are oftentimes more confounding or more confusing than helpful. So I don't use 4K in my practice. Really awesome questions. Thanks so much. Does anybody have any others before I proceed? And we can always go back to more select questions as we proceed. All right, keep them coming. I really like this. So let's move on to the next platform, which is going to be our Confirm MDX. And this is the test that Mdxhealth has had around for the longest. So it's the most validated of all of their products. Just for, I mentioned before, Oncotype was acquired by MDX a little while ago, but Confirm has been in their portfolio for a long time and really strongly validated. So where does this fit into our prostate cancer space or our paradigm? Well, as we all know, prostate biopsy poses its challenges. Where no matter what the type of prostate biopsy or approach to prostate biopsy you do, a biopsy sample will undoubtedly sample less than 1% of the gland, especially in our big glands that we're taking care of in Brooklyn. 1% is generous. So we know that prostate cancer is heterogeneous, multifocal. These are some buzzwords. Up to 25% false negative rate. So you could have a negative result, and still 25% of those might have actually been positive, just missed it. And then up to 50% of repeat biopsies actually detect clinically significant prostate cancer. So we're going to talk a little bit about DNA methylation, but before I go into what DNA methylation is, because it sounds fancy and kind of heady, I want to kind of talk about what epigenetics is and what the epigenome is. And it's actually very fascinating, that each one of our cells in our body, no matter what organ it comes from, has the blueprints for all of the different organ types in our body. So a muscle cell actually has the blueprints or the encryption for all of the different organ types. So skin cells, brain cells, liver cells, what have you. But it's really through silencing or activation of various genes that we then proceed to, tissue or organ development. And similarly, as we age or as our cells turn over, the epigenome, or this sort of turning on or turning off of genes, is really what's responsible for the housekeeping or the cleanup of our genome. And so when we look at tumors under the microscope, we're finding more and more through genomics that there's changes in epigenetics that are leading to silencing of certain oncogenes, or of tumor suppressor genes, or genes that would have otherwise suppressed a tumor from proliferating. And so it's by silencing these genes that's allowing the tumor to develop and progress. And DNA methylation is one modality that tumor suppressor genes may be silenced. And by adding a methyl group onto those genes, it actually silences or turns off the gene that would have otherwise protected you from developing this cancer type. And it's unable to perform its tumor suppressing duties. So it's really fascinating how it works. And obviously we could talk more about this, but how does it relate to prostate cancer? Well, there's one really driver tumor suppressor gene that's been found in up to 90% of prostate cancers, and that's GSTP1. And it's a detoxifying agent So again, cleaning up the genome to prevent genomic damage or these, damage, the mismatch repair genes that we see. It prevents the damage by detoxifying the genome. So what we're finding in up to 90% of prostate cancer is that GSTP1 is actually silenced by the addition of this hypermethylation group, or the CpG islands. And it was actually found to be the most common somatic genome alteration described for human prostate cancer. And what's the somatic genome alteration? Well, that's an acquired mutation, as opposed to ones that are inherited, or these are the ones that are germline DNA alterations or mutations. And those are the ones that are brought down through family lineage. The somatic genome alteration is the one that you acquire throughout your lifetime. An associated tumor suppressor gene that's been found to be associated with prostate cancer is the APC gene. And when it's silenced, it's associated with tumorigenesis and growth of these tumors. And then RASF1, again, not quite as strong as GSTP1, but it's also associated with cell cycle progression and prevention of apoptosis. So again, the cancer cell wants to survive. It wants to take over the human body. It's sort of this sinister mirror image of what our cells look like, that want to try and replicate what the cell is doing, but continue to take over and proliferate. So through the upregulation of, through the methylation of these tumor suppressor genes, the prostate cancer cell is allowed to proliferate. So I want to bring up a concept of a halo effect, or cancerization of a tumor. So you have your primary tumor, which we all know and we want to try and identify. But say your biopsy enters the prostate near the prostate tumor that you may have missed. Well, the cells around that tumor may have actually started to undergo this hypermethylation or oncogenesis through the silencing of the tumor suppressor genes. And you can find it in an area around the tumor. And the area, well, we don't exactly know the distance, 1 millimeters, 2 millimeters, 3 millimeters. What we do know is if you're taking a systematic core, 12 core, 15 core, 18 core biopsy, you are getting a template of the prostate that has overlapping zones. And so if you study the area around the tumor, you may be able to either identify an area that will become cancer or that is nearby a tumor. So it's a very powerful tool to be able to say on a negative biopsy, which didn't find cancer, if you can find hypermethylation of these cells, then you might be able to actually predict who's going to develop prostate cancer, or if you may have actually prostate cancer nearby the core that was taken. And that's where Confirm MDX comes into play. In over 55 published studies, that's a lot. In over 5,500 patients, the Mdxhealth was able to analytically in the lab verify its utility, and then take it into the clinics and clinically validate it, then show that there was some reduction in overall cost to the healthcare system through some health economics and the health economic validation, and then clinically, again, validate this through various and multi-ethnic, racially diverse populations, validate in various cohorts to demonstrate its utility. So what does it look like? So again, this was the study out of Hopkins, the Brady group down at Hopkins, that showed that this DNA methylation in a negative prostate biopsy was actually correlated, and I want to show you, with the subsequent diagnosis of prostate cancer. And what you're looking at here is what the odds ratio is for developing grade group 3 and above, grade group 2 and above, Gleason 7 and above, in a subsequent biopsy. And what Confirm MDX showed was that it way outperformed your traditional methods such as age, biopsy, percentage positive biopsy, PSA, and atypia. I mean, ASAP forever has been, the recommendation for ASAP is immediate rebiopsy, right? Because that's the thing that tells you, oh, I may have skived the lesion. I might have gotten right next to it. But rather than jumping right to that biopsy, look at this, the odds ratio of 15.8%, the odds ratio of 15.8 versus 2.4 for confirm MDX versus atypia. And that's really outstandingly powerful. So you can tell a patient, I'm concerned because that one biopsy core that I took is hypermethylated, and I'm going to change our follow-up strategy after your negative biopsy because this is signaling to me that it may be a higher risk area. And what does that look like on the report? It's so cool. You know, you get a report that shows the breakdown of all of your cores from where you took them, the whole mapping of the prostate, and which ones were, you know, non-methylated and which ones were hypermethylated. So right here, I would say to myself, all right, that's a positive confirmed MDX, but not just positive or negative. I can identify the left mid area as a possible area that I want to sort of focus my needles next time, in addition to probably another MRI, but I'm going to hyper focus and maybe even saturate that left mid area because I probably either missed something or something's going on that may be developing soon. So I'm going to consider a repeat MRI or a sooner PSA in that patient and possibly even a sooner repeat biopsy based on this distribution map of the methylation groups. So it's pretty exciting, you know, that you can actually drill it down to the area of the prostate. And a negative result really puts my mind at ease. It almost puts this patient into a routine monitoring patient. You know, like patient had an elevated PSA, and then we went to biopsy, and we had a negative biopsy with a negative confirm. That patient is probably going to get a PSA in a year for me. So the negative predictive value for clinically significant prostate cancer is 96%. And for all prostate cancers, including, you know, that grade group 4 and high risk group, 90% negative predictive value. So very strong and, you know, I think very clinically useful. I try and really narrow down the things that I add to my practice, again, in an underutilized sort of a resource limited setting. I don't have access to everything under the sun necessarily. And, you know, we have to pick and choose what we use very carefully. And this is one that I think can impact your treatment paradigm, you know, very strongly. So I'm going to stop here again and field some questions about the Confirm platform. I see Dr. Small here from Montefiore. Thanks for joining. How does the halo effect change the prostate with prostate size? So good question, hard to answer. And I think that the reality is you would have to have a lot of benign prostates in you know, whole mount specimen, which hopefully we're not doing too many of. But I can tell you that the company off the record is looking into this. But the larger the prostate, you know, you can only really determine the halo around the needle that was taken. And so if you have a 100+ gram prostate and you're taking 12, 13, 14 cores, you have to imagine that there are areas that are going to be missed. And that the halo effect doesn't, or that cancerization doesn't extend, you know, all the way out into the entire prostate. It's really just going to be sort of around where a tumor's developing. We have a question from Vineet. Is there a time lapse after the biopsy that the test cannot be done? For example, 12 months. I'm going to pull in Erica here. I think the answer is you can actually go back 30 months. Is that accurate?
That's correct. And Confirm MDX is the only test that you can use immediately following a biopsy, right? The tissue's already been removed. We don't have to bother the patient again. So when we can't do PSAs, we can't do MRIs, you can absolutely still do Confirm MDX. And like you said, Dr. Weiner, that actually goes back 30 months from date of biopsy. So you can go back on a biopsy that was up to 30 months old and run Confirm MDX still. Absolutely.
I just want to say clinically, though, the strength of Confirm MDX for me is that right after a negative biopsy, it changes the way I subsequently take care of that patient. So if I have a negative confirm, then I'm not going to see that patient for at least 6 months, but possibly a year if the PSA and other parameters are reassuring. So I would say that I probably wouldn't go back and do the Confirm MDX necessarily, but you could. Do you use Confirm MDX for all biopsy negative patients? Great question. I try to. I think that it's really valuable. And actually, we're doing a study with some of our students looking at what PSAs do post biopsy. And as we all know, because we take care of these patients day in and day out, PSAs fluctuate like crazy. After biopsies, when those PSAs go up, yeah, I mean, it's reassuring that you have a negative biopsy, but that PSA rise really is very confusing. So if I have a negative biopsy and a negative confirm, I feel much more comfortable about how I take care of that patient subsequently. So I try and unfortunately, my hospital system doesn't let me use reflex testing. Some practices will allow you at negative biopsy to automatically send it off for a confirm or Oncotype, or GPS. But I'm still stuck in my old ways. But in my practice, we actually have to actively order it. And so obviously I work in a setting where we have various providers, sometimes taking care of these patients, but I really try hard for our negative patients. I'll even go back and not 12 months necessarily, but a month or two, and try and pick up some of these negative biopsies that we missed. So for Confirm MDX that shows methylation, does the high percentage of finding grade group 2 or higher influence you on doing a targeted biopsy of that location versus observing closer with more frequent PSAs? Yes, I would say that it depends on the patient, actually. If I feel like, say it's again, an older patient with a lot of comorbidities and a PSA of 5, we get all these consults and referrals for patients with PSAs in the 5 to 8 range who are over 70, who, by all of the recommendations shouldn't really be getting PSA screening, but they do, and they're anxious. And so we end up, if the select maybe led us to do the biopsy, we will then do the biopsy. So for those patients with one core that's showing hypermethylation, but it was a negative biopsy, I will probably just watch that patient closer and then get an MRI at 6 months maybe. And again, this is just my practice. But if I have a young patient, 50s, with a PSA of 5 to 8, who has a negative biopsy and 1 or 2 cores that were hypermethylated, I'll probably repeat that biopsy sooner with a concomitant MRI to help guide it. How long do the results take to come back? It's really pretty fast. I would say on the order of 2 weeks. It depends sometimes on the insurance, but it's really within a month they come back. And then we have one more. The persistently elevated PSA, previous biopsy shows no detectable prostate cancer, so a negative biopsy. But now you're considering doing a second biopsy. How does the Confirm MDX result, positive or negative, influence repeat biopsy decision? I think we kind of touched upon that. Persistently elevated PSA, negative biopsy, with a negative Confirm MDX, I'm monitoring that patient. I'm monitoring that patient with a PSA if it's really high, at 3 months, and maybe 6 months. But if it's sort of borderline elevated and kind of creeping up, with a negative Confirm, I'm feeling more comfortable with the 6 months follow-up. If you have a positive Confirm, I'm getting an MRI at 6 months, and then probably rebiopsying if there's any concerning findings on the MRI. All right, great. Loving this Q&A session. So let's move on to our third and final platform, which is the GPS score. And this is something that the audience may be a little bit more familiar with. This is something that is sort of a space that I think is more often talked about. And there are a few competitors in this space. But I find that this particular assay is also really, really valuable. So let's jump right into it. So going back to our original pathway, we have a patient who came in with an elevated PSA to biopsy or not to biopsy. Select was maybe positive, we biopsied them. If it was negative, we did a confirm, and the confirm was negative. I'm happy, I'm relaxed. We're monitoring this patient. Confirm was positive, maybe we're a little bit more on edge. But say that biopsy was positive. Now we have a biomarker, a molecular assay that can help us in our treatment decision pathway. So I take care, like I said, of high-risk patients at baseline. So African-American, Afro-Caribbean, Latinx patients, baseline higher risk. So the decision to move forward with active surveillance for a long time was a controversial one. And with the advent of these tests, I've been able to now, with a lot more confidence, put these patients on active surveillance and have no second thoughts about it. So furthermore, it not only helps you decide active surveillance versus intervention, but the GPS scores we'll talk about in a few minutes, it's actually been proven and validated in the unfavorable, intermediate, and high-risk space in terms of treatment intensity. So let's take a look at that in a little bit more depth. So we know about 290,000 new cases of prostate cancer each year, and still about 35,000 patients are dying from prostate cancer. And I see patients like this, young, healthy patients, otherwise healthy, coming in with new metastatic prostate cancer, just from lack of screening, or we have some patients who are coming up from the islands, didn't have access to healthcare. These are the really sort of sad cases, and it's hard because we can treat them, but we can't cure them at that point. So the goal, really the exciting part would be to try and risk stratify these patients accurately at the onset. And we use genomics and radiomics, the introduction of radiology in combination with the omics, the genomics, epigenomics, all the different omics you can think of. And we've been able to use these tools to then personalize the treatment paradigm even more, with more accurate diagnoses and the less on the morbidity side. So some of the challenges in risk stratifying patients with prostate cancer, well, again, going back to that buzzword, multifocal heterogeneous disease, meaning that of your 12 cores, one may be grade group 4, one may be grade group, one may be grade group 2. It could be totally heterogeneous. And your needle may have just hit the grade group 1 and missed the grade group 4. And furthermore, to that point, there may be undersampling. So you may miss the disease altogether, or what you catch may be, a lower risk profile. And so what does the 12-core biopsy represent? And then also a really important question that I ask my team all the time is, what's the true biological potential of the tumor? Are we dealing with a wolf in sheepskin? Is this something that's really, kind of scary if you look under the hood a little bit? Or is this truly what the pathologist called at the surface level under white light microscopy? Is that what they're looking at? And what's it looking like underneath? And I'm not calling out pathologists. Certainly with AI technology, things are going to change. But I can tell you that there is variability within our pathology department on what we're seeing as far as reads. So these are agnostic tests that sort of pull all of that subjectivity out and leave you with an objective result of what this biologically is doing, sort of what's the characteristic of this tumor. This was a nice study initially by Dr. Klein out of the Cleveland Clinic in 2014 and followed up in Journal of Urology in 2018. It's looking at the chance of missing adverse pathology at the time of radical prostatectomy. So I want you to turn your attention to the biopsy cohort here. So Gleason grade group 1 here, 6,000 patients. And these patients, some of them underwent radical prostatectomy. And of those patients that had a grade group 1, which I probably wouldn't be operating on this time, full disclosure, but 3% of those ended up having grade group 3 and higher, and then 6.1% had non-organ confined disease. And of the grade group 2 patients, 12% of patients had grade group 3 and higher, and 17% had non-organ confined disease. That's pretty staggering. So, what we're finding is that on biopsy, we're probably underrepresenting what we're finding at the time of definitive treatment. So how can we skirt around that? Well, we can use a genomic biomarker and other tools. So we have the DRE, the PSA, MRI, certainly helpful. Try and get them on as many patients as we possibly can. The biopsy and Gleason score will play into this clearly. And then you can add to this the GPS score to help personalize and individualize how you're going to decide on treatment for this patient. I want to take a step back here and just make a call out to the GPS score as compared to, say, Decipher or Polaris, which are some of the competitors that all of you have heard about. The adverse pathology definition for GPS is grade group 3 and higher, or T3A, which is non-organ confined disease. So these are things that are clinically important for me because I don't want my patient to get to the point where they're advanced before I'm intervening. This is compared to Decipher, which is, they use the clinical endpoint of T3B disease, meaning invasion into the seminal vesicles. I don't know about you guys, but that is late for me. And so all of the, endpoints that are derived and the numbers that you see are derived on the T3B definition of adverse pathology for the other, for Decipher, but T3A and grade group 3 and higher for GPS. Another reason I like this test. So what does abnormal gene expression actually matter? Like, why do we care as clinicians? We care if it involves, patient outcomes. And what we're finding is that abnormal gene expression, upregulation of certain genes, results in adverse pathology, biochemical recurrence after treatment, nodal spread, metastases, and prostate cancer specific mortality. And how did they derive these genes? Well, this is another area that I want to really highlight here. So, in the basic science in vitro labs, identified 727 candidate genes, and then went to whole mount prostatectomy slides and looked and identified that there were some 288 candidate genes. But then here's where GPS really, separates from the pack, is they actually took it this step further and identified that 17 of those 288 genes were actually important on biopsy samples alone. So in your office, when you biopsy a patient and you're sitting there with Mr. Jones and you're trying to predict if Mr. Jones is going to have adverse pathology or recurrence or mets or death, you want to use that information based on your biopsy, not based on your prostatectomy, because you didn't do the prostatectomy. You're trying to decide what is going to happen based on that biopsy alone. So those 17 genes consistently performed on analytical tests, and they are found in as low as 1 millimeter squared of tissue, of RNA tissue. So that's compared to the other tests, which require 5 times the amount of RNA that GPS requires. So you can do this on an exquisitely small amount of tissue, of tumor DNA and RNA. And what they're finding is that these 12 actual cancer genes and 5 housekeeping genes, for comparison, they spread out into 4 different cancer pathways. One, androgen signaling, which is obviously important for prostate cancer; cellular organization, which is important for all cancer types; stromal response and cell proliferation, again, all cancer types. So how does it work? Well, what we do is, they take we do the biopsy. Biopsy comes out positive. You send off a slide. You don't have to rebiopsy. You don't have to get any more tissue. The pathologist sends off the slide that you obtained. And RT-PCR, which is basically a fancy, cheap, and efficient way of taking RNA, turning it into DNA, and amplifying that DNA so that it can be run on an assay and can be evaluated. So RT-PCR is run and evaluates for these 12 prostate cancer genes. And then what you get is a result based solely on the gene expression, those 12 genes. The GPS result is solely based on tumor genomics. They then take some of the clinical and pathological risk factors and add it in, and then you get a separate risk assessment, which is really nice. You have a completely agnostic, solely based on tumor genomics GPS result, and then you have a risk assessment as well. And those things can help you make a decision on active surveillance versus definitive treatment. Ultimately, what it does is helps you predict adverse pathology, distant Mets within 10 years, and prostate cancer death within 10 years. And I'm actually going to show some data that they extend the evaluation or analysis out to 20 years, and all these parameters continue to hold up. So the GPS helps determine treatment options, both for low and favorable intermediate risk, which is going to be your main driver as a urologist or an extender, physician extender in a urology practice. This is going to be your driver. Are you going to put this patient on active surveillance, or are you going to go to definitive therapy? But you can use it in the unfavorable, intermediate, and high-risk patients too, to determine the intensity of your treatment for this patient. And we'll go into each of these. We're going to break them up into separate categories. So let's start with our main sort of, driver, as I said, the workhorse, which is going to be your GPS score in a patient who has a positive biopsy and was found to have low or favorable intermediate risk disease. So your grade groups 1 and low volume favorable intermediate risk grade group 2. So do you decide on active surveillance versus definitive treatment? And this is the genomic biomarker with the most data in this space. So, level 1, whatever, like this has the most validation in the low and favorable intermediate risk patients of all the other tests. So again, the process was through prostatectomy study, then they narrowed it down to the biopsy specimens, and then they finalized the ins and outs of the assay through an in vitro analysis, and then used a prospectively designed clinical validation study in actual patients, 395 patients. And what was found here, which I love, is that by 20 units, so this is putting on my I'm in the clinic right now, and I get a GPS report. For every 20 units that GPS report goes up, you're going to see an odds ratio of up to like nearly 2 of all of these adverse outcomes, adverse pathology at radical prostatectomy. So again, every 20 units, you're going to see an increase in odds ratio of having adverse pathology at the time of radical prostatectomy. And same study here, we see for metastases and prostate cancer death, same thing. The very low risk, low GPS, low risk of Mets. Intermediate risk, higher risk. And that high risk, you're seeing significant logarithmic increase of risk at 10 years for metastases, and almost mirror image here for prostate cancer death. Obviously, prostate cancer takes a while to take hold of the patient. And so, the prostate cancer death statistics are always going to be, especially at 10 years, are going to be a little bit lower. Now, Brooks et al. So Brooks was an understudy of Dr. Klein at the Cleveland Clinic. And this study from Urologic Oncology in 22 showed, again, that adverse pathology at the time of radical prostatectomy was associated with poor outcomes. 17% had distant Mets at 20 years if they had adverse pathology. And these are patients who were eligible for surveillance initially, but elected for radical prostatectomy. And so these are patients who prostate cancer mortality of 6% at 20 years. So clearly adverse pathology is a predictor of these poor prognostic metrics. And what that led to was the subsequent study, which is to then include the GPS assay at 20 years to see if the GPS assay could predict distant Mets and prostate cancer specific mortality. And it does very strongly. hazard ratios of 3.6, and then for distant mets and prostate cancer specific mortality of 4.3, very strong p-values for these. So GPS assay is an extremely strong predictor of predicting distant mets and prostate cancer specific mortality at 20 years. Same study out of the Journal of Clinical Oncology, one of the higher impact journals. You can see here that GPS was a strong predictor, as you go up the scale of GPS of prostate cancer mets and prostate cancer specific mortality. And then here, I like this one a lot, the ROC curve. In red, what you have are your basic clinical parameters, stage, PSA, et cetera, and Gleason score. And you see the area under the curve of 0.772 for distant mets. Well, when you add in the GPS score, that area under the curve goes up to 0.82 for distant mets and up to, same thing for prostate cancer specific mortality. So really adding in quite a bit of strength to these clinical parameters, which, I find extremely valuable. I would be remiss if I did not discuss MRI, because you're going to get an MRI on all of these patients. So MRI certainly improves the detection of clinically significant prostate cancer. New England Journal papers, Journal of Clinical Oncology, Lancet, very strong articles. And I would say this is the gold standard MRI. We're getting them. It aids in better assessment of extracapsular disease and seminal vesicle invasion. But, as a colleague once put it, the MRI likes to show, likes to demonstrate the size and location, but the GPS assay, it kind of gives the personality of the tumor. So it's going to tell you, is this thing, is this going to act like more aggressive? Is it going to act less aggressive? What's the personality? What's the characteristic of this tumor type that an MRI certainly cannot tell you? So again, MRI is certainly valuable, but you got to look under the hood a little bit more to find out what's truly going on biologically. And the GPS predicts all of these very clinically relevant outcomes. So, we're not talking about just sort of some, foo-foo outcomes. We're talking about adverse pathology, biochemical recurrence, distant mets, prostate cancer death, validated in lots of studies. But let's just take a minute to compare GPS to MRI. And again, they are not mutually exclusive. I use them together. But if you look at GPS compared to MRI, this was a study out of UCLA in 2018 in the Journal of Urology, looked at 134 patients, underwent MRI fusion biopsy and then subsequent prostatectomy. And they had GPS assay performed before the prostatectomy. And the GPS assay was very strong in predicting adverse pathology at the time of prostatectomy. 3.2 odds ratio with a very strong p-value. And the only other thing in that multivariable analysis that was significant was a high Gleason score, which is obvious. I could have told you that. But what's interesting was that the MRI kind of fell out there and was not significant in predicting adverse pathology. And then in a subgroup analysis of these same patients who had favorable intermediate risk disease, it didn't even include the others, because the only thing that was significant was the GPS score with a very strong odds ratio here. So GPS was a significant predictor of adverse pathology in this subgroup analysis. All right, so let's talk about what it looks like from a provider's perspective. We still, large studies, meta-analyses by Kuberberg and Womble, these are really strong studies. They're still showing that for low volume, low risk or even favorable intermediate risk patients, that only 40%, 48% of providers are embarking on active surveillance for these patients. But what's really nice and interesting is to see that with the GPS assay in these 4 studies by Delara and Albala and Ure and Lowenrit, they showed an increase in utilization of active surveillance, which we should be doing for these low risk and favorable intermediate risk patients, of 21 to 29% increase. So I can attest to this, because active surveillance is an extremely important part of our armamentarium. And sometimes it takes a little bit of negotiation with the patient to sort of walk them back from a cancer diagnosis. But if you can tell them and you can tell yourself that you have a reassuring GPS score on top of this low risk pathology, I feel much more comfortable, and I fall into that that 21 to 29% where I'm very much embarking on all patients with those disease parameters if I have a reassuring GPS score. So you get a report, and you'll get the patient's GPS result. And in this patient, it was 30. So the median is 28, and it's based on patients with NCCN favorable intermediate risk with intermediate risk profiles. At a median of GPS 28, my general cutoff, actually I say intervene above 30, below I can feel a little bit more comfortable sitting tight, but I will tell you, and I'm probably going to get some questions about this, what GPS score do you pull the trigger on? It really depends on the patient. It really depends on the patient. Again, older, comorbid, I'm looking for excuses not to do a radical prostatectomy. Younger, healthier, these are patients that a GPS of 30, I'm a little bit concerned about. So what you do is you take this, and so you get a likelihood of adverse pathology. And if you look here, it falls into low, intermediate, and high risk. And this patient falls into the intermediate risk category of having adverse pathology at the time of radical prostatectomy. And on page 2, you'll get some more outcome measures, which are that adverse outcome, likelihood of an adverse outcome or high-grade disease, non-organ confined disease. And then you'll look at the other adverse outcomes like METs and disease-specific mortality. So again, going back to what I talked about, the definition of clinically significant disease in this space is higher than Gleason grade 3 or above, and then also PT3A and higher. And yeah, I find this very valuable. These reports, and not only do I have them in the patient's chart, but I also give the patient a copy of this so that they can use this in the discussion when they go home with their families, and they can talk about their diagnosis of cancer, but really reassure the family as well. So just to switch gears a little bit, just some patient scenarios that you may encounter. So this is kind of fun, a 62-year-old gentleman with a PSA of 9.5. We have a lot of these patients, right? Most of my men don't necessarily look like this. They, from different racial backgrounds. But again, clinical stage T1C, which is what we're largely seeing here. So grade group 1, 7 cores positive. Grade group 1, I'm still, even with 7 core positive, I mean, my antenna is up, but I'm getting that GPS to help me determine, is this that wolf in sheepskin, or is this a more significant player? And so this gentleman got, the physician's pre-GPS recommendation was active surveillance, which is, kind of where my head would be at. But then we got the GPS result, and it was 32 in a young, healthy male with a risk of adverse pathology of nearly 30%. And so after the GPS, the physician changed the recommendation, underwent radical prostatectomy, and lo and behold, grade group 3 at the time of radical prostatectomy. This is a huge win, right? It's PT2, it's organ confined. This patient is largely cured. You prevented this patient from progressing, and you intervened at the right time. Another patient, 58, a little bit younger, PSA of 5, again, clinical T1C, grade group 2, but only 2 cores positive. I'm actively surveilling a number of these patients, but my antenna, again, is up. So physician pre-GPS recommendation is a radical prostatectomy, but then at the GPS result, it was 12. So this is biologically very inert. It's a less aggressive sort of genotype than the patient in the prior scenario. So he's still at a risk of adverse pathology of 24%, but this patient then, with that information, along with the patient's physician, elected to proceed with active surveillance, allowing him to preserve his continence and potency for a few years. Likelihood, probably going to come off active surveillance at some point, but you can rest pretty comfortably knowing that it's not going to happen anytime soon. sort of that, there was a JCO article a few years ago as an editorial, and they called it the tortoise, the hare, and the eagle phenomenon. And you're trying to figure out which is going to be that slow creeper, the hare who's moving a little quicker, or the eagle who's flying across, and really progressing quickly. So I think this one allows the physician to be a little bit more comfortable knowing that we can watch this patient a little bit longer. All right, so let's go back to our treatment paradigm. So how does GPS help us in the unfavorable and high risk sphere? So in this paradigm, I would say that by and large, it's going to be more likely that you're going to see a radiation oncologist using this for their radiation patients, but I'm certainly using it to help me intensify or de-intensify my treatment for patients, particularly in the ADT space. And I'm going to go into why I do that in a moment. So a little bit of a busy slide here, but I really want to kind of point your attention. So what it showed was that GPS assay was an independent predictor of BCR disease, METs, and mortality in patients with unfavorable, intermediate, and high risk characteristics. And so if you point your attention down here, the GPS cutoff of greater than 40 and less than 40 was where the hazard ratio shot through the roof. So a hazard ratio of 7 with a very strong p-value, you're noticing, you're going to see this as a theme moving forward, that cutoff point is really where the prediction dichotomizes. And lo and behold, here we see a group from Cullen et al. In 2020 in the Gold Journal. They looked at patients with favorable intermediate, unfavorable intermediate risk disease, and they looked at their GPS scores in unfavorable intermediate risk patients. And what they found is that patients who had a GPS that was less than 40, they acted much more similarly to a favorable intermediate risk patient. And then the ones that had a GPS of higher than 40 were almost parallel or overlap with the high risk patients. And same thing with disease METs. You can see they stratify into favorable and the high risk based on that GPS cutoff of 40. And then this was a radiation oncology study looking at 238 patients, 69% African American. Again, kudos to the the organizers of this study because we really too often see underrepresented populations just not in these studies high enough. But NCCN unfavorable intermediate risk categories, high risk and very high risk, and the median follow-up was 7 years. And what they showed, again, very strong predictor of distant METs and prostate cancer death independent of race. So the GPS, again, strong indicator of these important outcomes. Same study looked at distant METs and prostate cancer death. That I want you to pay attention here, 0 to 40 and 41 to 100. 41 to 100 is the dotted orange line here, and you can see a very clear branch of METs and prostate cancer death with an inflection point around 5 years for the death. So you get a report, and again, that cutoff line is around 40. And here the report stated that 50. But I want you to notice that in the disease characteristics here, Mdxhealth dropped the adverse pathology because we know they're going to have likely adverse pathology with with the unfavorable intermediate risk or high risk patients, or even very high risk patients. So it's not as important of an outcome. We're looking more at the distant METs and the prostate cancer death. And you can see, based on this patient's unfavorable intermediate risk, they had a 23% chance of METs within 10 years and prostate cancer death within 10 years. So I want to just take a moment to tell you how I use this. If I have a patient with unfavorable intermediate risk disease or high risk disease who's undergoing radiation, I'll get a GPS score. And if that GPS score is less than 40, for unfavorable intermediate risk disease, I'm typically giving 6 months to a year of ADT. And for high risk patients, I'm giving 2 to 3 years. So if the GPS score is greater than 40, I'll give them ADT commensurate with the high risk profile. And if the GPS is less than 40, I'll keep them in their unfavorable intermediate risk category. Similarly, if they're high risk, but they have a GPS less than 40, I can de-intensify their ADT to maybe the 2 years as opposed to the 3 years. So this is objective data that can really help answer some of the difficult questions that we have on a day-to-day basis. So just to wrap things up, a couple of case scenarios. Again, we have a 70-year-old gentleman with PSA close to 9, clinical stage T2C, so we're feeling something on the DRE, with grade group 3 at the time of biopsy. So his initial recommendation, he's a healthy gentleman, was radical prostatectomy plus adjuvant IMRT, but got the GPS to see what the intensity of his treatment should be, and his GPS was 21. So this is really a more sort of favorable acting grade group 3, with the prostate cancer Mets at 5% or less, and less than 1% of prostate cancer at 10 years, the death of prostate cancer. So this patient underwent solely radical prostatectomy and eliminated that immediate adjuvant IMRT. And then another case scenario here, we have 66-year-old gentleman with a PSA of 9 again, T2C, grade group 2 on biopsy, and 6 cores positive. He was going to go for a radical prostatectomy, but his GPS score was 42, so above that 40 cutoff. And with the prostate cancer Mets risk of 10-year Mets at 10 years, 14%, this patient underwent a radical prostatectomy with radiation therapy and 6 months of ADT, just given his longevity, and he was healthy, and also this biologic potential that was much more significant. So I'm going to wrap this talk up going back to our initial slide, which is the really comprehensive menu of options that you have for prostate cancer patients with Mdxhealth. Again, I like it. One-stop shop. I got one rep who's awesome. I send everything directly to him, get my results quickly. Everybody in my practice, knows this person. It's one person, one point of contact, one biller, and we can really walk this patient through from beginning to end. And so, yeah, I know there's a lot of competitors out there, but this is the one that I've found to be most useful in my practice. So with that, I will stop talking and I will open it up to the group. All right, so why don't we answer a few of the ones that are active in the Q&A. So we have a patient with elevated PSA with urinary symptoms and proceed with select MDX. Comes back positive. Do I proceed with a confirm MDX instead of proceeding with biopsy? So thanks for the question. So confirm MDX is after the biopsy is already performed and you're taking that biopsy tissue, sending it off. And if that's negative, then you can rest assured that, rest pretty well that it's going to be an actual negative biopsy. And if it's positive, then you have to be a little bit more cautious. The select is really deciding to biopsy or not to biopsy. So if I have a positive select, then I'm proceeding with a biopsy. And then let's see. So do you think there is a role for GPS in deciding if a patient should have focal therapy versus RP? Great question. I think that, certainly with the confirm kind of tells you where it's going to be located. Your GPS is going to be based on where the biopsy was located. You can actually identify which of these cores was sent off from your pathologist. For me, it's not really the determinant in whether or not these patients are going to get focal therapy or not. For focal therapy, if it's not sort of regionally located within the prostate, if it's multifocal, these are patients that I'm going to shy away from. And also the Gleason score is really a driver for me. I would say for me, I use the GPS more in terms of intervene or not.
Any other questions for Dr. Weiner? Right. And just so you know too, Dr. Krishnan, we are currently starting up a couple focal therapy studies to see how, GPS can assist in that area. So kind of stay tuned for that because we might have some exciting data coming out here in the near future. And if there's no other questions, then I'm going to kind of wrap up. Thank you, Dr. Weiner, so much. It was such a great talk. I hope that everybody got as much out of it as I did. A lot of great things there. If anybody has any questions, feel free to reach out. My email was on some of the Outlook invites. Please reach out to your local representatives. We did record this webinar and we will be downloading and editing. So if those of you, if you would like to kind of have it in your back pocket or rewatch it, please feel free to reach out to your local representative or reach out to myself, and I'd be happy to shoot that on over. And with that, I'm going to steal back the hosting duties, and then I'm going to kind of sign everybody out for the night. Oh, wait, we might have a Q&A last one. Oh, you're welcome. Dr. Krishnan says thank you. So you're very welcome. All right, everyone, you all have a wonderful night. Thank you so much for joining us. Bye, guys.